Case number 12, which is a last case, 83-year-old man with a lot of CHF. Dr. Kini, Dr. Kovacic there.
Yeah, you see there, 83-year-old male. I'm going to the summary case because this is the last case.
Yeah.
NYHA class 3 who has severe bioprosthetic valve dysfunction, mostly AI, very minimal AS, STS mortality about 5, and he was deemed high risk for a second re-op because of comorbidities as well as frailty. So here we are. It will be a percutaneous valve in valve, and of course we have chosen the Evolute 26 millimeter. This is not the Pro, the old Evolute. And I think the question would be the same in this kind of valve-in-valve situation. That Evolute definitely, the data has shown, is a better valve service since it is a supra-annular, and you will get a better valve area.
Great. Let's look a little bit at the imaging so we can be in a little bit of a fast pace here.
Yeah, we are fast pace. So if you see that, JK, you
just to show you, very tortuous access. We normally go up and over with a 018 wire, safety wire. In this case, just too tortuous. We tried for a couple of minutes. It was just difficult. So we've gone without the safety wire in this case. Vessels are not calcified, so it's very reasonable in this case. Go to the slides, please. Go to the slides and show us the next slide.
Let's go to the presentation slides, please. The history. This
Echo,
is
you
Echo.
can see a lot of AI in this case. It's really the predominant problem in this patient is AI from a failing valve. And Dr. Chowdhury, do you want to comment?
Yeah, sure. We can see we are imaging with a pediatric probe. We are looking at a bioprosthetic aortic valve with marked degeneration and probably flail leaflet. And when we turn on color, we can see there's wide open aortic regurgitation.
Wide open. Great. Next slide, please. You can see here the angle is very reasonable, about 45, 50 degrees. Next. You can see here this is a 27 CE valve. It's 20 years old. The diameter across the valve is around 23 millimeters. The perimeter is around 72. Right on the border unit, for a traditional native valve, what we're doing would be between a 26 and a 29 evolute. In these valve-in-valve cases, because the structure is rigid and we're not going to be expanding it, we're usually going with the smaller size. So this is going to be a 26 millimeter evolute valve. Next slide. There you can see the coronary height, very reasonable. Next slide. This is important here. You can see on the right-sided panel the distance between where the theoretical valve is going to sit and the orifice of the left main is about 6 millimeters, suggesting that the risk of left main occlusion is not nothing, but it's probably fairly reasonable and low in this case.
Yep.
Next.
Very useful.
Next. Here the access, you can see no calcium whatsoever, quite tortuous, but no calcium. We did put a rigid Cook sheath up because of the tortuosity, so we didn't have any issues with kinking, but that all went fine. Next. Here you can see tortuosity. Next.
Super tortuous, yeah, but not much
Next.
calcium.
There's the valve 26 evolute, the old valve without the skirt, as we said. And next. I think we're done. I think we can go. This is
a very important point that how to implant valve in valve. You see the old surgical valve. We will show you on fluoroscopy. You see the ring. The goal is same, which is shown the planned implant, the lower on the right hand side, where you see the evolute sitting. So you have to keep it at a 0 level. 0 level of
half a dome.
The right picture on the screen is the most important because that's what we're going to be gearing up for during the fluoroscopy. So got to be on the high side.
So this is where we are, right? This is the
Let's
view.
see where
back to the fluoro. Yep.
So we're going in. Very well aligned that you see that we're cutting this valve right across. We have the confident wire in the ventricle. The patient already has a permanent pacemaker, which is a good thing.
So when you have a problem, so I think I'm going to rotate it a little bit, this side or that side.
Yeah. Yeah. No, the codo.
May not be 0, right?
Yeah, I know.
Huh?
Let's just try.
No, you're okay. Okay, we're going to start releasing now. We have Alan Stewart, our surgeon. He's going to start releasing. He's diving down. I'm pulling back. As we start to flare, okay, start pacing at 150. Good. Nice, 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 right?
Nice.
Good.
Well, make sure it stays there. It's
yeah,
always
I know, I
electric.
know. Okay, stop.
It's
stop.
very good.
Okay,
It's very
stop
good, the
pacing.
Let's go
level.
to the
The level is very good. Excellent.
Stop
Go to the
pacing.
two views.
Okay, now you go and check we have to check couple of views just to make sure we are nicely
just
aligned,
take a
no
cine here.
parallax.
The cine is good.
Okay, let's cine. I think no parallax,
No
right?
parallax. And
There's
let's go
no
the other way,
parallax,
other
and I
way,
would
other way.
release this valve.
Okay.
The other view here is
Other
about this.
panelists, any ideas? I did thumbs up. Dr. Lucia?
Yeah.
Yeah. We are
I
okay.
think it's a good position. Can we see the
Going forward.
hemodynamics,
Yeah,
the pressure?
I did.
Wires back.
Good, nice. Nice,
Yeah.
nice, nice. Is released, nice, really
Looks
released.
good, hardly any AI.
Good.
Okay, watch how the cone comes out now.
Okay, looking good.
Very good.
Nice.
Yeah,
Okay,
looks good by Echo.
echo looks good.
Yeah, Echo looks great.
We are going to clap.
Can
I
you
want
show
to-
us your hemodynamics?
Okay.
This off to Pedro Moreno.
You will try to get into the LV. Give us a pigtail. Come out.
We can take this out. Yeah, we have a sheath. Get a pigtail ready.
Beautiful deployment.
Thank you, guys.
You know, I find the Evolute a little more slippery on the bioprosthetic valves than the old CoreValve. And so this precise dropping it into exactly where you want it is, I think, a little more challenging, but you did it beautifully. And I think that rapid pacing here is a good idea because it does have a tendency to want to pop out a little bit.
Yeah, I mean, obviously, I think we're not exactly at zero there. We're at like -3, I would say, or -2, which I think is okay. Let's look at the hemodynamics
I
of
think
the
you got to
double
leave like
vertical.
0.5, not exact 0, but maybe 0.5.
Yeah, exactly.
You
We'll
cannot
just-
do 0,
I think
0.
That's close.
Yeah.
I mean, I would also be very uncomfortable with a 0. And just to be clarified, we're using the first
Okay, let's show
case,
the hemodynamics here.
the Evolute Pro,
Beautiful.
which has a skirt around, but here we don't need it that much because there is already the prosthetic valve in. And you can see
Definitely,
that the hemodynamics are perfect.
Improved.
No gradient and the diastolic before. Are we showing the hemodynamics? You're seeing it. And the
Great.
diastolic improved.
Great, excellent. Great case, Anu. Congratulations. And Dr. Moreno will read the discussion.
One aogram.
Okay, let's see. I think by echo we see that there is no AI and the diastolic pressures are great. We're just going to do an aortogram, Anu.
E up. Good. Don't inject immediately. See the nice placement of the valve? Good.
Beautiful.
Inject. Beautiful.
Very good.
Yeah.
That's perfect.
Yeah.
I think the key here is the same with the bioprosthetic is that Evolute definitely is a better valve and as you see there, absolutely like we barely get any gradient with this valve. In valve and I think positioning which we showed you in that last slide, how you position it and when you're above, when the valve is flaring up, you pace 150 or so and that's the time you release it fast and just
Very good
go
result.
check it in couple of views to make sure there's no parallax and that the everything is the valve is nicely placed around the ring and once you're sure you just release it. Okay.
Any comments from the panel?
Now